Pleural effusion. General features. The primary things to check for are respiratory distress, tachypnoea, and cyanosis. Look for clues to the underlying etiology, as detailed below. Malignancy. There are several signs that would suggest this. Sputum pod. Cachexia. Hoarse voice. Clubbing. Tar staining of fingers. Jaundice, hepatic metastasis. Horner's syndrome, ptosis, meiosis, anhidrosis, and anophthalmos. Neck lymphadenopathy. Superior vena cava obstruction. Scar, from previous thoracic/breast surgery, CT-guided lung biopsy or pleural biopsy. Breast abnormalities, nipple retraction, deviation, and mass. Tuberculosis. Sputum pod. Lymphadenopathy. Systemic lupus erythematosus. Rash. Rheumatoid arthritis. Joint deformity. Nodules. Respiratory examination. General inspection. Look for thoracotomy scar. Chest wall deformity, thoracoplasty. Asymmetric chest wall movement, reduced on side of effusion. Trachea. If deviation is present, this will be away from the side of a massive pleural effusion, or towards that side if there is coexisting ipsilateral collapse. Palpation. Examine the supraclavicular and cervical nodes as above. Expansion is decreased on the side of the pleural effusion. Percussion. Check for dull sound on percussion on the side of the pleural effusion. It will be stony dull if the effusion is large enough. Auscultation. Reduced or absent breath sounds, same area as above. Reduced vocal resonance/tactile vocal fremitus, same area as above. Further discussion. Pleural effusions are divided into exudates and transudates on the basis of Light's criteria, Table 11. The PACES examiner is likely to ask what diagnoses you would consider in a patient with a pleural effusion who presents on the general medical take, Table 12. Investigations. Chest radiograph. Performed to confirm the presence of an effusion, Fig. 5. Pleural fluid. If there is associated pneumonia, is the fluid parapneumonic or is it an empyema? If it is opaque/turbid and with a foul smell, then it is clearly an empyema. In cases that are less clear-cut, the pleural fluid pH is probably the single most useful test, with empyema strongly suggested by a pH 7.2, which is an indication for insertion of an intercostal drain. If there is no associated pneumonia, is the fluid a transudate or an exudate? Measure the fluid and serum protein and the LDH, Table 11. In addition, organize the following as standard tests. 1. Microscopy and culture, both anaerobic and aerobic, and for TB. 2. Cytology, Table 13. 3. pH. And in cases where diagnostic uncertainty remains, check the following. Glucose, a value 1.6 mol/L typically occurs in an effusion associated with TB or rheumatoid arthritis. Rheumatoid factor, suggests rheumatoid arthritis is the cause of the effusion. Amylase, suggests pancreatitis. Adenosine deaminase, this is high in cases of TB. Pleural, Abrams, biopsy. Pleural biopsy may be indicated if initial pleural fluid analysis does not yield a diagnosis, and is of particular value in those with an exudative pleural effusion in order to exclude TB or an underlying malignancy. It is standard practice to perform this with an Abrams needle, which is a large blunt-tipped needle with a hook to catch a sample of parietal pleura. The diagnostic yield in pleural TB is increased by 20 to 40%, but it is much less, around 10–20%, in malignant disease. It is important to remember that because this is a blind, unguided procedure, a negative result does not exclude any diagnosis. Thoracoscopy. Medical thoracoscopy is primarily a diagnostic procedure, but it can be used for therapeutic purposes. The most common indications are evaluation of the unknown exudative effusion, staging of diffuse malignant mesothelioma or lung cancer, and treatment by talc pleurodesis of malignant or other recurrent effusions or empyema. Local treatment of spontaneous pneumothorax is also an indication. Indications for pleurodesis. The indications for pleurodesis are symptomatic recurrent pleural effusion or spontaneous pneumothorax. Many substances have been injected intrapleurally in an attempt to obliterate the pleural space, the mechanism for most being simply to create an inflammatory reaction that leads to fusion of the visceral and parietal pleura. Commonly used agents include talc, doxycycline, silver nitrate, and povidone iodine.